the Bosch and Lomb session. And this Bosch and Lomb session, we are going to talk about the new presbyopia lenses, IOLs, which Bosch and Lomb has come about. And we have got fantastic speakers. I request Kamal Kapoor and Sri Lakshmi to come over and occupy the seats on the dais. Along with me is Dr. R.C. Paul, co-chairing this session. And we'll have, I think, because two speakers are not available because of some, Kamal is covering. Kamal is covering for Piyush Kapoor. And if we have some time, then I will probably present on stellar as a light as well at the end of the session if we have time. But we will have more discussions. And before we start, and I want to know from the audience, how many of you are using multifocal lenses on a regular basis? How many of you are using EDOF lenses on a regular basis? So more of EDOF than multifocal. So I think the way forward is going on the EDOF lenses. And without much ado, I think we should start the session. I request Dr. R.C. Paul to say a few words.
So many options in the cataract replacement with the presbyopic IOL. So here in these sessions, basically, while we evaluate our experience, that something we get, something we less. Now the more questions is regarding the high order aberrations, either be it EDOF or be it, whatever presbyopic IOL. So let's see what's happening, and then we'll talk about this presbyopic Bosch and Lomb lenses.
Who wants? I think Sri Lakshmi can go first. Sri Lakshmi is a very, very dynamic surgeon. I've not seen. She was the right hand and the left hand for Dr. K.P. Reddy, who we all know is the father of refractive surgery in this and phakic IOLs in this part of the world. And she's got her own hospital, the Win Vision Hospitals in Hyderabad, and very, very good surgeon, good phaco-refractive surgeon. I'm sure she's going to throw some good light on this new technology which is available. It's a really fantastic technology, the LexSmart. And the Bosch and Lomb, I think, a few years back was in the oblivion, but they have come up because the inherent quality of Bosch and Lomb is the quality. The high quality and the high standard of their machines, whether you take Invista lenses or the LexSmart or for that matter, any lenses, I think. What's the other lens you have, that spherical lens? Dakshina? Looks good. Looks good. That also is really fine. And over to Sri Lakshmi, are you ready with the presentation?
Yes, sir. Yes, sir.
And how many of you are using Bosch and Lomb lenses here? LexSmart or any, LexSmart you're using or Invista? Using LexSmart or Invista? Invista, how many of you are using Invista? I think is probably the first glistening-free lenses. In fact, we have presented a paper. I have presented a paper along with Mark Packer way back, about 7-8 years back, I think, when Invista came to the market in the Ophthalmology Journal. And this is a very good topic, surgeon experience with extended range of vision lenses. What's happening to the... Sorry.
Lose connection or something?
Okay.
अभी चल रहा है? Okay. Good evening, one and all. At the outset, I would like to thank Dr. Mohan Rajan sir for the nice words and Bosch and Lomb for the opportunity, and also AIOC. So I was asked to speak on what all are the lenses regarding this extend depth of focus IOLs. My experience I'm here to share with you. Before this, I just would like to say an incident. When I was a very young 4-year-old.
Little louder.
Little louder?
Yeah.
Now I'm audible better?
Yeah, better.
So I was only 4-year or 5-year-old, I guess. We all went to Tirupati. My grandmother, by then, she used to have very thick glasses. I think she had her cataracts done. Those days, there was no IOL. Was implanted. So poor lady, the glasses fell down and broken. And I remember viewing Lord Balaji's darshan with one of the glass pieces she could get, and that was imprinted in my mind. Like, whenever any cataract patient comes, I would like to offer them, no glasses at all. So these were the adverts we used to give when presbyopia clinic started. Majority of cataract patients, majority of them, although these Googlers and all ask, but majority of them, they think if you put a lens inside, they don't have to wear glasses. Still under the wrong notion. So we put this is the lens you opted for. So with this, you need to wear glasses for far, intermediate, and near. And then now this lens multifocal, no glasses for anything. Now comes the another option we added: glasses not required for far, and glasses not required for near, but you have to wear, other way. Glasses not required for far and intermediate, but near you have to wear. That's how the EDOF we introduced. So, and I love this caption. When Dr. Arthur Cummings underwent his LASIK way back, he put an article, he wrote a nice article about his experience. So I was very impressed with this caption. I remember, I always wanted to use, the best eyewear is no eyewear at all. So when I started my practice of multifocals, I really love multifocals. I offer majority of my patients these multifocals. From bifocal to trifocals, we have seen how these lenses also evolved. And the so-called glare halos problems also, majority of these manufacturers addressed it. In fact, these multifocals I implanted in all my family members. But then why this new lens? So I think there's so much of noise about these glare halos, photic phenomena. And some patients, because of the knowledge on social media or whatever it is, they come and ask. One of the patients asked me, doctor, how many multifocals you removed from the eye? I said, why would I do that? No, my family doctor told me this is not a good one. It will be very troublesome, very bothersome when you drive night times and all. I don't want these lenses. You give me other option. I don't mind wearing glasses. These were the things, the multifocals, they have a wrong notion about it. But anyway, all said and done, now the manufacturers have found out the solution. So that's how I slowly started adding this EDOF in my practice. So now slowly, I think it's on rise in my volume of cataracts. So that ideal EDOF lens, the optic principle, unlike a monofocal, when there is a focus shifted, there is a blur circuit at the retina. But an EDOF can create a single elongated focus, which extends the focus. So a good depth of focus is created so that a good intermediate vision is processed, but without compromising the retinal image quality. So we have various EDOF IOLs now, but is there any ideal EDOF? We have the small aperture IOL where the field is reduced, so it is only supposed to implant in non-dominant eye. And all know about the diffractive IOLs, also refractive. Again, the same kind of trouble of photic phenomena, glare and halos. And then there comes this non-diffractive IOLs. We have various optic principles, and I have used all of it, whatever I'm showing, except that small aperture. So each surgeon has their own preferences. Each one has you want to drive a BMW, or depending on the engine performance, how you choose your cars or mobiles. Similarly, I think majority surgeons have their own preferences in terms of whether it's monofocal, multifocal, or EDOF IOLs. So I personally now zero it upon 3 non-diffractive EDOF IOLs. VVT from Alcan, this optic principle, it has a central elevation and curvature change. So these two elements acting simultaneously manipulate the wavefront, stretching forward and stretching backward, creating a hyperopic and myopic kind of focus. So where the manipulation, in turn, gives here continuously range of your focus. So that's how this principle, and then there is not much of photic phenomena, but every lens has its own demerits. This is a beautiful one, but then in the near vision, you have to tell your patients that it cannot achieve perfect near vision, although it gives good distance and intermediate. So that's why it's become easy for the surgeon to impress the patient that, I will provide you this, but you have to wear glasses. So acceptance from the patients is easy for the surgeons to handle, unlike in a multifocal situation. So my data with Alcan VVT is, so majority of them for the distance, they got 6/6, like above 80% of them reading 6/9 for far, and for the intermediate, 78% achieved N6, and more than 80% got N8. And for the coming to the near vision, this 54% achieved N6. This is my own data. So more than 70% were reading N8. And this want to share. After having done so many VVTs, then when they claim that it's behavior like a monofocal, so definitely it has a role in certain pathologies involving optic nerve or retina. So the gentleman owns a very popular TV channel in Hyderabad, and he has a very huge room, and he sits and he watches every day the news, like these even the majority that TV channel, like media tycoons, they also manipulate the politics. Yeah, so he wants to watch the TV from one certain distance, and also want to look at he's a very tall guy. So, but don't know why when has one other surgeon implanted a multifocal, then he was having very bad kind of retina, totally burnt out, extensively done PRP. So the other eye, when he came to me, I gave VVT, and definitely he was feeling much, much better with its outcome than the multifocal implanted in his other eye. Magnificent from IOCare, it is also a surprise for me. I don't know, I gathered data of this lens from various information sources. So it is having hypersphericity and a negative on the anterior side and positive on the posterior side, which is helping these depth of focus around 1.5 to 2 diopters. That's what they claim. But then definitely a better kind of depth of focus was achieved by this lens. And it's a really pleasant surprise for me, because economically, even if patient cannot afford this expensive multifocal or EDA IOLs, this has definitely a place. And this is my sister's friend. She had very small pupil, and long time ago she had third nerve palsy. She came to me for the very dense cataract. So I thought, let me put Magnificent and check whether will she, because I thought it is kind of not a very good outcome I expected in her case. But a real surprise for me with this lens and in her eye, I don't know, look at her pupil size. Probably the pupil size also plays a role in this, because small apertures, giving more depth of focus. Combined elements, I don't know, she really was so happy. And the other eye also, it was a normal eye, but then eventually in binocularly, she's extremely happy. And Magnificent, this is all I collect from the 30 years of data. So the distance for far with this lens is almost 61%. Do you have a time bound? I can.
Maybe another 2-3. Yeah.
5 minutes.
Yeah, 5 minutes. Okay.
And for the distance is almost 6'9", 80% of them achieved 6/9, and intermediate vision almost 80%, and the neo vision was around 50%, N6 rather. I was talking about N8 rather. So then comes this LuxSmart from Bosch and Lam. So this is a non-diffractive IOL. The optic principle in this is it has a central EDOF center located in the central 2 mm area, and it has combination of fourth and sixth order with opposite signs. That's where this lens has the point of, when you have opposite signs of spherical aberrations acting together, the depth of focus definitely has a enhancement rather than one spherical aberration like negative spherical sphericity, but combination with opposite signs is the one which increases the depth of focus. And it has the refractive zone which meant for the distance, and there is a transition zone in between which helps to maintain the contrast sensitivity, that means no light loss. And it has forefixation which sits very well, and it's a hydrophobic, and it can go into 2.2 mm incision, but till now they have not provided with the toric version, so far I implanted only non-toric. So this is my data of LuxSmart. Today morning I had this free paper presentation on this. So 35 patients, 50 eyes we presented. With the even age group, if you see, I put 24-year-old also. So I'll show you that video. So, and we included 5 myopes. 2 patients are having ERM, but very not clinically significantly affected their visual acuity. And 1 patient had amblyopia. And majority of them underwent femtophaco procedure. And bilaterally, we implanted in 30 eyes. And 20 patients had single eye. So the mean UDVA logMAR achieved was 0.22. This is like ANSI standards. That is how EDOF lens should have. And for the distance, 80% of them were reading 6/9 on Snellen's chart. Only 6% of them lost more than 3 lines, that is 6/12 partial, due to the myopic shift happened. Initial cases, there was a myopic shift on biometry. So then we started, the A constant was 118.4 for the optical, but then, surgeon A constant also important. That's how we understood that it should be little whatever showing, 0.4, 0.5. Below that you should, we started doing that way. Then the results were definitely optimized. And coming to the intermediate vision, 80% achieved N6 and 96% achieved N8. And similarly, the neo vision, 76% achieved N6 and 86% achieved N8. And so far, no photic phenomena. None of them, we asked for a questionnaire and none of them complained photic phenomena. And on Ardent chart, we checked the contrast sensitivity. There's a 10% loss of contrast sensitivity with this lens. And majority are very happy. 80% of them achieved spectacle independence. And defocus curve also was assessed bilaterally. This majority of them achieved 6/9 on Snellen's chart. So the IOL master was on 700, we choose and Barrett's universal 2. Initial cases, I started taking my calculation on Varian, because I like Varian. The reason is that other biometrics only they predict this spherical error, but then on Varian it gives also sphere and cylindrical predicted error. So that's what I used to take this. So, but then I realized I should use this only for the incision location. And this lens needs priming. It's very important. You have to inject BSS in the either side of the cartridge and a little bit of visco at the tip of the cartridge, and you have to wait for 30 seconds before injecting into the bag. The reason is that priming with the BSS, it activates the inner layers of the cartridge. So this will help when you inject into the bag after waiting for 30 seconds, it will not get stuck. So sometimes we do unconventional. No, you know, these Bausch & Lomb people are very strict, stringent in terms of in their implying the technology or anything in terms of IOL or anything. So sometimes we go unconventional. Since they did not give me the toric one, so I used arcade here, and also priming I just put over the BSS. So in a couple of cases I got stuck with the lens. So this here I got away, but this is very important to be careful with this lens. This is an interesting case I want to share with you guys. This patient, I implanted ICLs. He's having -8 with 0.75 cylinder was his refractive error prior to the ICL. But unfortunately, in his right eye, he developed anti-subcapsular cataract. And left eye was quite normal. After 6 weeks, he came back to me saying, for first 10 days only, I was very good vision in my right eye, and then it started troubling. I couldn't see anything. Then it was so unfortunate. I didn't know what to do. I didn't want to put any multifocal because in the other eye, having good vision, and whatever little halo we see in ICL patients, they eventually they stop complaining. You know that aquaport, that's hole in the ICL. But what lens I should give to this young man who did his pharmacy and is started working, and then I asked them, there's a lens available. It was 11.5, I think. So I immediately explanted and replaced with Lux Smart. And for the initial couple of weeks, because of the manipulation of explantation and then surgery, there was a little wound edema. He was having a little hazy vision, but then eventually he achieved 6/9 and N8. I was also, could sleep well after this good results. In the literature review, there were 2 studies with comparison with monofocal of this implant, and both showed good intermediate vision. And okay.
Because we have 2 more.
Yeah.
Comparing 2 people.
Yeah. Yes.
To cover 2 people.
Sure. So all the studies were showing this good intermediate vision, but then pupil dependency was there in the recent study. They said there's a pupil dependence with this implant, and they targeted myopia of 0.25 and achieved 75% did not require glasses, but they did in inactive patients. But in my study, I implanted this lens in many active professionals, including few of my doctor friends as well, and with mini monovision strategy, this lens could provide all ranges of vision and make them, free from glasses. Thank you.
Thank you, Sri Lakshmi, for your exhaustive talk on this Lux Smart and the EDOF lenses. And a quick question to R.C. Paul before we go on to the next speaker. R.C., do you use Lux Smart regularly?
Yeah, quite a few cases.
Quite a few. Why do you prefer Lux Smart over the other EDOF lenses?
This is basically a very good IOL, and the technology is such that we face less, the aberrations.
Yeah. Absolutely. I think this is a very good message. Please understand that all the multifocals or the trifocals, they have got rings. As long as the rings is there, the halos will be there. Especially when you are not hitting the bullseye consistently. If you make them myopic, a little -0.5, -0.75, it is possible sometimes, despite the best optical biometry, everything. So you can make them a little more, the halos can be a little more. Of course, the new trifocal, the halos are much less. The photic phenomenon. This is one of the most important factors as far as the dissatisfied patient is concerned in a trifocal lens. So we are moving from trifocal to EDOF lenses. As I told you, the EDOF lenses do not split the light. The multifocal, trifocal split the light. Because it's splitting the light, the halos are coming, number one. And also there's a decrease in the contrast sensitivity.
Yeah.
Okay? So I think Kamal is going to talk about it. This stretches and shifts the light. So over to Kamal Kapoor, he doesn't require any introduction. I call him the Delhi Hurricane. Kapil Dev, as you all know, is a Haryana Hurricane. He's the Delhi Hurricane. And he's one of the fastest surgeons. He's got a huge chain of hospitals, more than 30 hospitals now?
No, sir, 18. You're flattering
18,
me.
okay.
18 now.
But very soon it will become 30, I'm sure. And Kamal Kapoor, a fantastic speaker, and every time he's a faculty in our surgical strikes also. By the time I finish one femto, his surgery will be over in 2 to 3 minutes. And I used to tell him, don't go so fast, because people have to listen to you and learn from you. Over to Kamal.
You're very kind, sir. Thank you to Bausch & Lomb for giving me this opportunity. For those who know me and those who don't, I live, breathe technology. I would have been a physicist if I was not a surgeon. I can rip open a machine and put it back together, not because I'm a good surgeon. I'm a good surgeon because I understand machines. That's what the difference is. So, okay. Now, as we are talking, I'd just like to add what Dr. Srilakshmi said. Amazing presentation, very, very lucid. The reason why would you, when you're operating a high myope, the caveat is, if you're using an EDOF, go for a little bit more myopia. I've got huge number of lenses, 400 plus 500. BNL probably knows, probably highest, probably in Asia. We've done in the last couple of months, nearly crossed 500 by now. And my experience tells me when you're working in high myope, leave it 0.75 myopia. The reason, these people have larger pupils. So smaller pupil, like one patient you were showing had a small pupil, and I was mentioning Dr. Mohan Rajan, this patient will be overcorrected for near and overcorrected for distance and have a beautiful near vision. So EDOF lenses are sensitive to a pupil size, but not as sensitive than the multifocals. But if there is anything you need to understand about EDOF lenses is your pupil size, your anterior chamber depth, and your corneal surface. If these three things are in order, but of course the macula, then everything will be fine. So presbyopia, I call cataract surgery in iatrogenic presbyopia. You're probably making the patient more presbyopic than he was probably. And what is the solution? We are looking for the Holy Grail. Holy Grail is, you know, the grail where the blood of Christ was supposed to be there. People are looking for it. Still not there. Is EDOF the answer? That we will see. I have no financial disclosures for this particular topic. Is EDOF the broken link which is going to join the monovision, the bifocals and the trifocals? I was one of the very high users, like Dr. Srilakshmi, of trifocals and bifocals. I feel bifocals are over, practically finished, and monofocals are going to die a slow death as the EDOF technology improves. So I'll be comparing two talks. Dr. Piyush, my friend, is not coming, so I just sat there and made his presentation also. So I'll be talking about spherical aberrations. If you understand spherical aberration, you'll understand the EDOF technology better. Then we'll understand about the different types of EDOFs. Then we'll talk about the pupil size, how it plays with the EDOFs, how do corneal surface disorders affect it, and your patient selection and pupil decentration. So categorically, presbyopic IOLs are in 4 types. I don't need to tell all of you. These are different categories of IOLs. Luckily for me, Dr. Srilakshmi did touch a lot of them, so I will just breeze through them. Mechanism of working are either you have a diffraction, either you have a refraction, or you have a pinhole effect, or a true accommodation like crystal lens. So the principles are the monofocal has a single point focus. The multifocals or the trifocal or the bifocal have 2 or 3 discrete focus intervening with a zone of blur. We will see a diagram there. And this zone of blur is the biggest problem, because this is the point where the patient starts losing light. There is a light loss. This is the area of blur. Now this is how it happens. In a monofocal, you'll have a single point source of light, crystal clear vision, but yes, the moment you move away from that focal point, it's gone. In a bifocal, you'll have 2 points of focus, but the intervening zone between these two is a zone of blur. These patients will have, if they have a large pupil size or if they are prone to glare and halos. In a trifocal, you will have 3 of them. How does an EDOF work? EDOF has a single point of focus, but it's elongated over a point. And that is done by playing with the spherical aberrations, creating some diffractive zones or some patented refractive zones in the center to give you this continuous zone. So the advantage is there is no light loss. You're just bending the light. You're just bending the light over a longer period. So this sometimes can only probably give you a little bit of waxy vision on the out edges of the object, but by far and large, most of the patients are very, very happy with this. So let us understand the spherical aberrations first. We all know what is a positive spherical aberration. In a positive spherical aberration, the peripheral part of the rays are meeting before the focal point. In the negative spherical aberration, they are behind. The EDOF lenses, the real pure EDOF lenses worked on the negative spherical aberration. They play on the interior surface of the lens, make it more prolate in the center, cause more bending of light, so you have a stretched zone of focus. Now the next question would be, if this was so simple, why weren't we doing it earlier? Why not increase the negative spherical aberration and give 3 diopters of AG? Why just stop at 1.52 or 1.75? The reason is when you play with the negative spherical aberration, there is a very, very small zone you can play around with. We'll understand why. Because if you increase the negative spherical aberration, your peripheral vision starts going for a 6er. This is what can happen. So this is the normal aspheric oil. We were talking about aspheric oils. The positive spherical errors and the negative. In the negative, you see there is a zone of confluence, the dark part. That gives you a tunnel straight beam of continuous vision. So enhanced monofocal lenses work on this technology, and the diffractive monofocals like the Vivity or the Synergy or the Panoptics, they use a combination of spherical aberration and diffraction. So the diffraction compensates for the other part, so that's why you can probably have a defocus curve of 3 diopters there without compensating the peripheral vision. So this is what can happen if you increase the negative spherical aberration. The peripheral image will go for a 6er. So there is a fixed amount you can play if you only want to play with the spherical aberrations. So the asphericity, this is what I've tried to show the audience is if you take the photograph through a fisheye lens, it's highly spherically aberrated. This is what can happen. The peripheral will get distorted. Now, this is just for a reference point. Now, look at when I talk about 0.2 logmor, it's 6/9.5 vision. Now, the definition of EDOF by the American National Standards Institute is any IOL which gives you N9 vision with a distance vision of 6/7.5 with correction. In 50% of the cases, it should be an EDOF lens. It's a very open-ended definition, which means if the patient is seeing 6/7.5 with or without glasses, and with the same glass he can read N9, in 50% of the patients, it's an EDOF lens. So that can happen with different kind of pupil sizes also. So it's a little loose definition, but I'm sure they're working on it. So if you see an EDOF lens, this is what you'll see across a zone till you reach 1.5 diopters of near AG. But if it was a monofocal lens, at 0.75, you'll start getting the fuzz or the shadow effect. So this is how an EDOF lens will increase your depth. Now, understanding types of EDOF lenses, this is a huge list. Now, Physiol, Isopair, they'll give you, so the Bausch & Lomb, J&J, Technis gives you supposedly 1.5. The marketing material says 1.5, but if you actually do an optical bench study and see, it is 1 diopter and the total zone of 2 millimeter. So it's actually a near depth of 1 diopters, but the company markets it as 1.5. But if you actually see the Bausch & Lomb LuxSmart, it goes to 1.75. Now, once you play with this lens and your cylinders and your blending vision, you'll see what magic you can create. Now, this is a category of hybrid lenses, hybrid refractive, hybrid diffractive, pure enhanced monofocals. I will not go into the principle. Dr. Sri Lakshmi has already talked about them. I have used most of these lenses. I've moved on, slowly used them and experienced them and had my fun with them and moved on. Symphony. Now, what are the issues? Why do these lenses never pick up? Why do these lenses never pick up like a rage? The reason is this. Sometimes you'll have a blurred vision, near vision, halos, glares, ghost images. Now, this is what a polyfocality will do. Rings will do to you. Now, these are non-specific. It's like Pandora's box. Any patient can get a bad result. With the best of surgery, you'll have an unhappy patient. So let's understand the photic phenomenon. You could have a point source of light. This is how a glare would look. This is how a halo would look. And that's how a starburst would look. This next 3 slides will help you catch issues in your patients. Now, patient, when he says he has halos, you have to ask him, do you see rings of distinct circle or a lens flare around the light object? If that is so, that's surely your multifocal diffractive lens. Just keep your eyes closed, that's what is causing it. Now, if the patient is talking about a glare, this could be a PCO bang in the center. A PCO is also known to cause a lens flare. We'll see how it looks. Now, this is what a starburst sign would. Starburst sign is classically seen in post-LASIK patients due to the interstitial haze in the initial part. Dr. Mohanraj and all those people who do LASIK surgery understand what I'm saying, and it tends to go away. But it can also be happening in PCO or polar cataracts. So if you have a central PCO, you could be having... Now, lens flare classically is due to an uncorrected astigmatism or astigmatism induced by the surgeon. You may have caused some astigmatism. So whenever a patient is complaining of a lens flare and he's saying, "Mere ko light stretch dikhta hai," please do a tracy if you have one, or do a refraction, and you will find these patients have some uncorrected astigmatism. So the pinhole effect, again, I'm not going to talk about. Now let us talk about small aperture, gone, finish. I've used a lot of visual lenses also. I used them in huge numbers, but then I slowly moved away because they were not up to the mark. They were not giving me the results even with blended vision. Beam shaping technology, VVT, I was just discussing with Dr. Mohanrajan. We've used a lot of VVTs, but over time I've kind of moved on. It works on a central raise principle of 2.2 millimeter, where there's an X-wave technology, and this is an added refractive zone in the center of 2.2 millimeter. It's very visible even on the slit lamp. Issue with these lenses can be very, very pupil size dependent. And if this lens decenters, it can cause high order aberrations. I have put this in some very VIP patients. I'm in Delhi, so you know there are all politician base are majorly in Delhi. I did put it in some top VIP politicians, and then I had burnt my hands, and then whatever is the story. So after that, I became slow. Now I look for pupil size. If somebody asks for a VVT, I look for the pupil size. Lucidus again I've used now. VVT we've already talked about. VVT will give you a 1 diopter correction. VVT, I'm talking about Eyehance, will give you near 1 hand, but Eyehance is a beautiful lens to be used if you want to close your eyes, and you can use this lens. Play with micro monovision, it'll do the job. What actually decides the actual quality of the lens is the modular transfer function. For all the people again who have tracy, they can measure the MTF of the lens on the machine. A trifocal lens will have a peak, a dip, a peak, and a dip. So these dips are the ones which are caused by the zone of blur. This is where the light is lost. So the patient may have loss of contrast at night. A bifocal will have 2 peaks, monofocal will have single peak, but look at EDOF. It has a single peak and it slowly eases out. So there is no loss of contrast. As the object comes nearer, it just blends in. So you have a clear continuous zone and slowly it fades into it. Again, this describes the whole thing. I will not go into the details. Now, this is how the lens is. The company says 2 diopters, but I think in my practical hands, 1.75 diopters. So the trick I do is, if I'm planning 2 eyes, I do the non-dominant eye first, overcorrected by the first myopia as long as it's on my biometer less than 0.55. So I hope you're getting what I'm saying. So I'm doing my IOL master, and my IOL master says minus 0.45 or minus 0.42. I use that lens for the non-dominant eye. And based on the response, I usually plan the second eye after 5 or 6 days. I want the ELP to settle down. Then I plan the second eye. It gives me a lot of playing range. So this is a trick I'm sharing. That's how we can get, and Dr. Sri Lakshmi was talking about, that's how you can get 80 to 90% patients 6.6 and 6. Because with both eyes open, they're doing fantastic. So if you're operating the non-dominant eye, and I'm sure you have so many times realized, patient is even 6.12 in the non-dominating eye, and the other eye is 6.6, he has no complaints. He's absolutely singing songs. So initially beginners, if you plan do the non-dominant eye first. When I do clear lens extraction, I plan the non-dominant eye first. I go for the first myopia as long as it's less than 0.5. Correct that, wait for 4 or 5 days. As long as the patient is little myopic, even if it's 6.9 parts, I'm superbly happy. Because the moment I correct the second eye, he's going to be N6, N5, and 6.6, both eyes open. And this is what the patient actually wants. So the lens is actually based on a very patented transition zone. It's called Optics Pro technology. The first order, second order, third order, and fourth order. The first and the third order are for near vision, and the second and fourth order are used for intermediate and distance vision. Now, again, I will not get into this, jump this, because I'll just skip the video. I'm just trying to show that I was doing a session a little while ago on astigmatism. So I am very, very, very intolerant of astigmatism. So a lot of times you're told that 0.75 astigmatism you should love to live with. But if you plan to give the patient the kind of vision he wants, attack the astigmatism whenever you can. So in case you can, I usually do OCCIs if the astigmatism is less than 0.75, or I shift the patient to a femto and reduce the astigmatism. On my machine, I can take it down to max 1.5. I can't correct beyond that. Otherwise, then it shifts to toric. So once I've done that, I put the lens in. This is an OCCI. I'm just showing you that. This is I've made another opposite incision and to correct the 0.75 astigmatism. So advantages of this lens are, it's a 4-point lens, it's very stable. It will not rotate, it will resist decentration. So remember I said, if your EDOF lens, because it is aberrated, if it decenters, it will cause high order aberrations. So instead of 2 points, this has 4 points. So resist decentration. The material is rock solid, it is very rigid, it resists decentration. It's totally glistening free. So you do not have these glistenings which you may see with other IOLs in this, and thus the quality of vision is going to be superb. It can be inserted through 2.2, so it's actually a refractive surgery. You're not inducing any astigmatism in these patients. There was a study done to compare the depth MTF curve of Vivity versus LuxSmart, and you can see that LuxSmart, the one in yellow, scores far more area under the MTF curve and gives you a better vision. For people who want to understand what the MTF curve in real life can do, I think I could not have found a better picture to explain to you. A higher MTF curve, you will be able to see till max the spatial frequency of this contrast loss. If the IOL has a higher area under the MTF curve, your ability to differentiate the finer lines to the highest point will be higher. So your ability to differentiate the contrast is going to be superb. So look for an IOL with a high MTF curve. Now this is a photograph with a lower MTF curve and a higher MTF curve. Now if the light was reduced in the first photograph, you will start losing the edges or the flare. If the lens decenters, and if it's a high order aberrated lens, if the lens decenters, it can cause problems. But the best part about this lens is it's a 4-point touch system. There are no zones which are separately visible. So the decentration will not affect the visual quality as much as the other ringed IOLs or IOLs with visible optical zones. So I hope I'm making it clear. If there's no visible optical zone, the decentration will not be that bad. So we've done 400 plus lenses, and this is the questionnaire which we talk to the patient. One thing is, please look at the height of the patient also. I get a lot of surprised look when I talk about that. I introduced this concept 2 years ago, 3 years ago. A taller patient is going to be more tolerant to your EDOF lenses. Even if you use a simple eye hands, patient will be more tolerant because of the height, the arc length of reading is higher. I'm nearly 6'2", and I'm 55 plus, and I don't need glasses. It's not that I don't have presbyopic correction, but my reading length, because of my arc length angle, is higher. But same person my age, probably shorter height, would need glasses. So taller patients, you can actually play around, get away very easily. Who are the patients to watch out for? Patients with small pupil, patients with surface disorder, short height patients, patients who are allergic to reading in the low light, and small pupils. These patients, you plan your EDOFs well. Always do the non-dominant eye first. This is a lesson I've learned over so many years, and all the things I'm sharing are practical, real type things. If you ask the patient that, are you okay seeing some halos but have good vision? Tick trifocal. And if you don't want halos, but you're okay with intermediate vision, 80% of your daily life you will not require glasses, tick EDOF. Guess what? All of them tick EDOF. You need to educate the patient. If the patient walks in thinking, "Bhai, aapne to mere ko bola tha paas ka chashma lagega nahi," wrong. leave the choice to patient. Well, okay, near glasses you want independence, fine, but there may be some photic phenomenon. Or go for EDOF, no photic phenomenon, but you may require some glasses in low light or stuff. All of them will go for EDOF. And this is an informed consent. So this is what works in my practice. So what are the things which actually work? Q value, keratometry, and astigmatism. If there's a astigmatism very high, don't think of EDOF. Dry eye, don't think of EDOF till you've treated the dry eye. Keratometry, very steep keratometry. In my practice, in my hands, I think EDOFs don't perform that well. 47, 48 keratometry, there is something wrong with the ELP and the anterior chamber depth. There's an issue. So, biometry formula, make sure the biometry is superb. If you have a very shallow anterior chamber, then also you may have some issues, 2.3, 2.4 millimeter anterior chamber in high hypermetropes. Pupil issues. If the pupil is very small, the lens will form perfect for near vision, but it will be not that good for distance. So plan under correction in smaller pupils. In large pupil, you can probably get away with large overcorrection also. IOL centration, tilt, refraction, and surgeon-induced astigmatism, patient expectation and counseling. If you worked on all these, you will have these advantages. The advantages of EDOF, more forgiving, less problems with glaucoma, more tolerant for ERM, no glares and halo, excellent night vision. So this is our study, similar like yours. 78% of our patients are 6/6 and 6 both eyes open. Your study said 80%, mine is 78%. And this is in nearly 108 patients. We've not done for all 400 patients we've done. 108 patients, study of 2 months. So my belief in this is moved up. I'm even operating my super VIP patients with that. I'm planning to operate my brother-in-law for the same lens for a clear lens extraction. So as I just said, 78% are in the target zone. Patient selection criteria I have mentioned just for repetition. Pupil size, again, very important. Look at the pupil size. Very shallow chambers, Fuchs dystrophy, small pupils in deep anterior chambers, other diseases, asteroid halosis. I don't use it in uveitis patients, retina detachments. Moderate myopia you have to watch out for. Moderate myopia patients are very difficult to make happy, because they are used to a very good, decent near vision. So you need to counsel them well. Fuchs endothelial, we closed. I think that's it, sir. Thank you. And toric EDOF, toric LuxSmart is going to be available very soon.
Friends, I think we should confess that it cannot be a better presentation than what Kamal beautifully explained, the IOL technology, how the EDOF lenses work, and also his experience with the LuxSmart lenses. But I want to ask you some questions. RC, you have any questions for Kamal? Yeah, okay. I want to know, because in high myopes, I tend to use, of course, explaining the situation to the patient, because these are all patients who are used to very good near vision in their life. I'm talking about very high myopes. Those patients, I tend to go in for a trifocal. Sometimes I've used even a Technis +4 lens in one eye and +3.25 in the other eye, because if they don't mind some decrease in the distant vision, but the near vision has to be very good. That's one thing. Second thing is, what Kamal has rightly said is, you need to sit down and do a math in the patient. Do a math and find out what exactly the visual requirements is. And depending on the visual requirements, suppose they want to go play golf or driving, those are the patients you need to push them on the EDOF side.
Yeah.
Okay? Or if they're just sitting at home watching a TV serial and reading a book, those patients you put them on the trifocal side. So I think this is a broad classification, I would say. Of course, you need to go into the nuances of these things and find out if they are really bothered out, whether it's a type A personality asking too many questions. Then those are patients who are likely to complain of glare and other things. So how do you decide on number one? But what I have found out in my practice is that the new middle, what is the new middle? Can anybody tell me what is the new middle? The new middle is the near point has receded from 35 centimeters
to 40, 45.
to 45, 50 centimeters.
Absolutely.
You see how many of you are using the cell phone nobody is using at 35 centimeters. Nobody is reading a paper nowadays at 35 centimeters, because everybody is reading newspapers on the iPad, a tab, which is about 50 to 60 centimeters. Okay? If you see the Hindu paper sales and the Times of India sales, in Chennai, it has gone from 3.5 lakhs to 2 lakhs in the past 10 years. Why? Because people are now embracing digital technology for reading papers also. So if you are using the cell phone, it is here. If you are reading an iPad or doing a tab, it's here. It's no more here, 35 centimeters. Unless otherwise you are having housewives, house husbands, and of course mother-in-laws, those patients, you put them in the, because they are all staying at home and they probably read papers at 30-35 centimeters. In this way, I think the market for EDOF lenses is going to become very huge.
Absolutely.
The simple reason is, as I told you in the beginning, because in trifocal lenses, the problem is the halos and glare and the photic phenomenon. That will vary from one patient to another. You cannot predict. You tell the patient, okay, you will not, 100 patients, out of 100 patients, 3 or 4 will have a period of time will become all right. Some of them, they don't become all right because neural adaptation doesn't take place. There's something which, there's no technology by which you can find out pre-operatively whether this patient will go in for glare halos, whether glare persists or not. So, in that case, the patient is, how do you select the patients, Kamal? And Sri Lakshmi.
So, as I said, sir, first of all, Dr. Sri Lakshmi, I think, was reading my thoughts. My example to the patient is like, it's like selecting a car. If I give you, like, don't go by what I'm trying to say, or don't get tied down to it. Mercedes represents opulence, interiors, luxury. BMW gives you that grunt, that torque. For people who understand, the torque in a car is different than the BHP, brake horsepower. Torque is the raw acceleration which you get, and RPM is how fast you get that into that zone of RPM. And Audi is a mix of both. Audi gives you best of both worlds. So I tell the patient, this is an Audi. It gives you a trifocal, it gives you a monofocal, and the best of both worlds. So, and another trick I'm sharing with you is, I never tell the patient to use a particular lens. I say, okay, these are my favorite lenses. I never say these are the best, because that is contestable. That is actually contestable. There's no best actor also. That is contestable. So I use the word saying, these are my favorite lenses, and I would say, this is the premium in that category, and this is an affordable in that category. I don't say this is cheap, because when you say cheap or economical is a bad connotation. But affordable is a very pleasant word for good quality and yet affordable. So that's how my counselors are trained, and that's how we are able to run the kind of numbers we run. And there are some other EDOF I was talking about, I won't talk about them here. That's how we hit those numbers there also in a period of months, because you tell the patient rightly and never push him towards one thing. Then the patient might start thinking that, you're pushing towards one particular brand. And selecting of the patient is, in a multifocal or a trifocal, a very fastidious patient, I would stay away. Because I don't know whether he's that 4 or 5% of patient who's going to have photic phenomenon. And then he's going to eat your head off. Yes. I would push this patient towards a blended vision EDOF. Number one. Number two, case selection, as I said, very small pupil patients, I always undercorrect them. The first undercorrection on my 0. Again, how I select my cases, because these patients will have a myopic shift. Another one, especially for people who are not doing a lot of EDOFs, don't be fooled by your AR. Your AR is always going to be myopic. You shoot, the patient is 6'6", you shoot, it's minus 1.25, minus 1.5, minus 0.75, minus 1. Don't be fooled by it. That's the AR measuring through the central zone. That's supposed to be there. The central zone is at least minus 1. So don't be fooled by that. And if your optometrist puts minus 1, the patient will strain, accommodate, and still see through, and he'll be prescribed. But if he wears that, his vision for distance is gone. So never correct the low myopia on your EDOFs. That's again a trick I'm sharing with you. Leave it. That's what gives him the depth. So the pupil size. The surface disorders, if it's a chronic surface disorder, I stay away both from a diffractive lens and an EDOF. Then I go for micromonovision. Then I plan a micromonovision in such a situation. I operated my wife recently. She has a dry eye. I didn't use any one of them, and I put a micromonovision lens, both eyes. She's very happy. I knew, number one, my wife. So I wanted to stay happy. I said, if I put it in dry eye, I wanted to put Luxmart. If there was any issue because of the surface disorder, there'll be trouble. And I said the height of the patient, the profession and lifestyle of the patient. If he's a patient, as Dr. Mohan beautifully said, if he's a patient who likes to read a lot, read books, okay, you can go towards trifocals also. But majority of the patients are working at the intermediate. All of us are working at intermediate. Our mobile phones, and guess another plus point, in all your digital gadgets, all you need to do is increase the font by 10%, you're still able to read. So that's what we do. A lot of patients who are short-heighted patients and they've got a need of, say, Doctor Sahab, mobile mein dikkat hota hai. I just tell my optom to increase the font size slightly. I say, wow, wonderful. Because most of the reading is in a mobile phone now. And now you have foldable mobile phones. So you should know how, in your practice, and your team should know how to play around. And then you have more happy patients. So the next patient will just come and he will not say what he wants. He'll say, just put what you put in Mr. Malhotra. Because my friend on morning walk is very happy. So then you look up the records, or sometimes he'll say, koi smart lens dala, Doctor Sahab, aapne bahut smart lens hai wo. So that's how your practice grows. So be smart. To use technology, I always tell people, a smartphone is as smart as the user who uses it. You don't know amount of stuff you can do. Amount of stuff I can do on my phone is crazy. I can do graphics, I do animations, I do everything on my phone. So to be able to use a smart technology, you need to be smart first. You need to understand what you want and what the thing can give you. And then you can get maximum out of it. So similarly is with this particular lens. You just understand the optics and you get your hands on it, and slowly you'll realize the lens becomes a slave in your hand. Like a machine. Once you understand a machine, it'll play it through the way you want.
I think you hit the nail on the head. I think it's very important for people who want to use EDOF lenses. You want to give the best to the patients as far as the range of vision is concerned, the contrast, quality of vision is concerned. I think blindly we can go in for the LexSmart technology.
Yeah.
The simply, not because it's a Bausch & Lomb session I'm telling this. I'm just telling you because LexSmart is a fantastic lens. It's a beautiful lens, lovely injector, and it's a 4-point haptic. We have seen the experience. I think I implanted one of the highest number of Acreos Evo in the entire country, and more than 3,000, 4,000, 5,000 lenses and all we have implanted. And we have not had a single case of decentration of the Acreos Evo lenses because of 4-point fixation. Even if there is a capsular contraction, it doesn't decenter. So I think the biggest advantage is the 4-point fixation, and it's a hydrophobic lens. And the Acreos Evo, at least it was hydrophilic, so the yak cap rates were a little high. Here I think it's very good. I think the chair time has become less because of EDOF lenses. Otherwise in the multifocal you need to convince them, talk to them, back and forth, you have to tell them. That consumes a lot of your time, and ultimately you're not sure of your result. Also, here you can consistently hit the bullseye and make the patients happy.
The best
and
part
one
is
happy patient will bring you over 100 happy patients. But one multifocal patient will sit in the OP and spoil your OP. Make sure that other people don't come there and create a big... and I'm talking about a trifocal patient who is unhappy. Because there are more chances. I'm not telling that all trifocals. There are indications. Yeah.
I have a question for you.
Yes, no problem.
Which EDOF lens you prefer in post-refractive surgery patients?
I've done VVT, I've done LexSmart also.
I've done VVTs. Now my current favorite is LexSmart/Eyehance. I've stopped using VVT in post-refractive. Especially if the cornea flattening is less than 39, I don't touch that particular cornea with a central different raised optical zone.
What about the spherical aberrations, the pre-existing in post-LASIK patients?
That's
well,
exactly.
Hyperopic LASIK. Probably the hyperopic LASIK.
Hyperopic LASIK is a different
No, I'm talking about myopic LASIK.
It's a totally different
we have done
ballgame.
this LexSmart, I've done Lucidis also, I've done VVT also.
Sir, I also implanted, but
Yeah.
I was wondering...
Sir, on a lighter note...
No, the biggest problem we had in post-LASIK was the optical biometry. But now with the Barrett's formula and other things, you're able to get it right on target. And if we're able to get it right on target, then it's this thing why we should not use EDOF lenses. Any of these EDOF lenses are good for the matter.
So on a lighter note, when I was doing multifocals, a lot of multifocals, I was a very high volume user of multifocal. I had absolutely saved as a favorite one article on neuroplasticity because I had to sit and counsel the patient that there is a concept on neuroplasticity, it will take a few months for your eyes to get result. So I'd saved that as a favorite on my phone. So whenever a patient would say this, I would open that page and show it to him. Please go through this. I give you a link, go through that. You had to learn psychiatry to talk to patients of diffractive lenses. Unhappy patients are very difficult to handle.
Yeah, sometimes I tell the patient if they have halos, I say, excellent, sir. That's the reason. Your multifocal lenses are working very well for you. So you have to motivate the patient because these glare and halos is something, you tell them, very good, it's working very well for you because after some time maybe he may forget about the halos or maybe disappear also after a few months. And these trifocal lenses are really fantastic in that way. But you need to know where exactly you want your patient to be. That's important. I think you need to do a good preoperative counseling, know the nature of your patient, what is the nature of the activities he's doing, and then you need to, as I told you, whether he's going for high and occasional readers, because many of the patients say, no, I don't mind occasional readers. Yeah. +1, I don't mind. So, because I want good quality vision, I want to play golf, I want to drive, I'm very active. Because most of the patients are coming, they're not 70, 80 plus nowadays. That's a changing cataract scenario. They're all coming with 6'9", 6'6", because they're not able to drive at night. So these are not able to, because of the decrease in the quality of vision. Amit, anything you want to say?
Eyes closed.
For me, if you want to, I would prefer EDOF lenses or a high-ans, for the matter, not a trifocal. High-ans is fantastic.
See, IANS is more towards a mono. So I think maybe because it's a mental block we have, I think just wait another few years. The new mono is enhanced monofocal or think like non-blended zones. That is the future. That is the future.
I want to eliminate monofocals in my practice, either multi or EDOF. That's it. To offer them, no glasses. The best
that's why her hospital is called Win Vision. She wants to do only multi or... Asi, any comments from you, Asi?
Actually, in our practice, what we do, so when they say that, these questions of EDOF or multifocality or presbyopic lenses, we see in most of the occasions you don't need any glass. And honestly speaking, Dr. Mohan Rajan gave the importance. He uttered one word, most of the patients forget. Because this is a serious incidence in the patient life that had gone through the cataract surgery, went through so many counselings, expectation has gone up, down, so many complications. In their terms, it came from itchy eyes to watering, redness, whatever. But honestly speaking, after quite some time, everything settled down, so it passed off.
Yeah. Anything you want to add? I think, some questions from the audience we can take. How many of you are using LuxSmart lenses here? I think we took the question in the beginning, no? LuxSmart. We are
going to use it.
Going to use it after this session. Bausch & Lomb people are there, they'll give a 50% discount on them.
See, the kind of marketing from J&J...
Or they may give even 10 lenses free of cost.
Probably
for those who attend this
I
session.
think Bausch & Lomb people should do this.
Yeah, please.
In the one eye, monofocal, can you use a EDOF in another eye?
Why not?
And one
we
eye
have done
is
that.
Okay.
We have done that.
Okay. And one eye multifocal and another eye EDOF.
That also I have done.
I have not done.
That I have done. One patient recently operated is an ophthalmologist. She is very... it's about 3-4 months since, or even more than that, since she had a panoptics lens in one eye. Then other eye I put, she was very concerned about her halos. Then other eye I put VVT. She's quite happy. Quite happy now. Yeah.
I can share one experience.
Yeah.
One patient, I won't name the trade name, etc. So I had some presbyopic IOL and the complaint was as such, it was going to be explanted or exchanged. The other eye had the cataract. So we did the cataract surgery with a monofocal IOL, and you won't believe after the surgery, the patient said, I don't have any problem in both the eyes, and this is being settled. This is the real life experience. Yeah.
I think so. I think we should coax the patient to have the other eye surgery, not as Kamal said, I would wait for a few days. Because you can titrate, you know exactly where you stand in the first eye. I don't do dominant or non-dominant. First eye, I aim for emetropia. The second eye, I aim for -0.5. If it's a high-ans lens or something like that. So, I don't believe in the dominant or Okay, only my wife is dominant on me. That's a problem.
One point I'd just like to add is 32% of my practice of EDOF is the patients where I've done one monofocal earlier now. They're coming back to me after 2, 3, 4 years, and I'm doing EDOFs in these eyes. They are very happy.
Sir, you were talking about decentration again and again. How much decentration is there exactly?
37% of IOs will decenter by 0.8 millimeter. The moment you cross 0.6 millimeter, that's when things start playing up.
With because I'm doing a lot of flags as well, and then Kamal is also doing flags. Sri Lakshmi, you're also doing flags. RC, you're also doing flags. Yeah. All of us are doing flags, and if you have flags, probably the decentration rates, everything will come down. But I don't think it's 37%. Is it? Are you sure?
Yes, sir. So I can share the data with you because I did one study for care group, and based on Tracy, we did some back issues with some different types of IOLs, and of course I agree with you. If you add the total of flax, pure study group of flax, it's lesser.
No, with flax it's much less.
Much less, yeah. But yes. I'm talking about a significant decentration. So 37% of patients are decentered, but they are not causing any problem. That's what I said.
No,
they're not
with
visible.
The
moment you cross 0.65 and it's an aberrated lens, even if it's a negatively spherical aberrated lens, that is when things will start happening. The coma and the trefoils will start coming in.
Absolutely.
More so the comas.
I think both with the IHANS, as well as I'm talking about monofocal plus lenses, as well as with the EDOF lenses, the decentration can cause problems. Yeah, of course, multifocal or any trifocal for that matter. I think we are on time. And for the next session as well.
So regarding negative aspheric and positive aspheric, which one do you prefer?
See, positive spherical lenses aberrated are practically not marketed anymore.
Yeah.
They are not made anymore. All of them majorly are negative.
No,
just the Q which you go for.
No. What he is asking is that the central alone, there's a slight positive spherical aberration which is there in this high-ans lens as well as in the EDOF lenses. And that's why they are playing around with the spherical aberration there. But generally, positive spherical aberration is not the lens which will take. Okay, yeah, photo will take. We have taken a photo. Yeah. We thank the AIOS for this wonderful opportunity, and of course, Bausch & Lomb for giving this opportunity to us for conducting this session.